So good morning, everybody. Good afternoon or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the 4th Neurology Virtual Clinic, our one-of-a-kind learning experience. During this educational activity, our top-notch migraine experts will share with you real-world clinical cases. Therefore, I would like to invite you to interactively participate by analyzing the cases shared and vote whenever needed, as your participation will definitely make it a fruitful meeting. Migraine is one of the most common and most disabling diseases and represent the leading cause of years lived with disability at age of peak productivity. Fortunately, the therapeutic options for this condition have recently been expanded, particularly due to the clinical development of drugs targeting the action of calcitonin gene-related peptides, CGRP. So CGRP receptors are diffusely expressed across all the nervous system regions involved in the pathophysiology of migraine, including the cerebral cortex, subcortical regions, brainstem meninge, and trigeminal pathways, peripherally the dorsal root, trigeminocervical complex, and spinal cord. These findings have promoted the search for antagonists of CGRP and its receptor for the treatment of migraine. Specifically, 4 different monoclonal antibodies inhibiting the activity of the peptide, galcanezumab, fremanezumab, and eptinezumab, or its receptor, erenumab, have been developed, and several clinical trials have demonstrated their effectiveness and safety. Erenumab, the only monoclonal antibody targeting the CGRP receptor, was approved and was the first of this drug to be available for clinical practice in UAE specifically and the MENA region in general, although under very different circumstances than those reported in pivotal clinical trials. Real-world results are gradually being published. The aim of this webinar is to report real-world experience with erenumab treatment. Before starting, let me thank Novartis for sponsoring this educational activity. And let me thank our speaker for accepting our invitation tonight. In our first session, Dr. Ali Hassan will discuss the efficacy and safety of erenumab in clinical practice and will compare it to the result of the phase 3 clinical trial. Based on it, this drug were approved.
Sorry for the technical error. So will be back now.
Excuse me for this cut. I was introducing to you Dr. Ali Hassan. So Dr. Ali Hassan is a consultant and acting chief of neurology division at Tawam Hospital. And after graduation from Asyut University in South Egypt, he had his further training in the residency program in the University Hospital, which have more than 2,000 beds and a highly advanced neurology department. He completed his master's degree in neuroscience in 2003 and medical doctorate in neurology from Al-Azhar University in 2010. Dr. Ali has a long experience in neurology service in different Middle East teaching and tertiary hospitals. He worked for Ibn Sina Teaching Hospital, Sirte, Libya. Then he joined King Fahd Military Hospital in Jeddah for 3 years. And in 2011, he joined Al Ain Hospital. Then in 2017, he joined Tawam Hospital. He has many research research studies, especially in the stroke, vascular neurology, multiple sclerosis, and epilepsy. His main interests are stroke, headache, neuroimmunology, and neuromuscular disorder. He has a long experience in treating headache patients with Botox since 2014, with more than 500 Botox treatment for chronic migraine patients. He has special training in EEG and epilepsy in Case Western University Hospital, Cleveland, Ohio, USA, and he attended the Summer School of Epilepsy in Denmark. He has had many presentations in local and international conferences. Dr. Hassan, it's always the pleasure to have you as a speaker with us. Welcome, and the floor is yours.
Thank you, Maya, very much for this kind of introduction, and
you're welcome.
You make my life easy because you have a very good introduction for the CGIP medications, and I'm also informed our colleagues that we are lucky neurologists. Before May 2017, we don't have any specific medication designed for migraine except Botox, which even it was not designed for migraine. But after May 2017, we have a lot of medications and a lot of real-world data experience that reflecting our hand-on experience. Actually, UAE was a lucky country, was one of the second or third country worldwide to have these medications approved and used before many other countries in Western area even. So today we will be mapping about the progress of real-world experience in migraine prevention. As we said, it's a new era that is developed into approved in May 2017 and on. After that, we have many medication. Now we become 6 or 7 medication in this group of family of CGRP medications, which is specifically designed for migraine headache rather than used for any other disease. So we talk today about monoclonal antibody, which is target CGRP pathway, and what's the global status of these medications. So as of January 2022, Eunumab, Cakinizumab, and Finimuzumab was approved in many countries. Eunumab was the first one to approved worldwide, including USA, UAE, and other countries. Now it's launched in 56 countries worldwide, which is the most highest number of countries launched in CGIP, followed by Cakinizumab, 40 countries, Finimuzumab, 38. And the country reimbursed or paid for the Eunumab is 29 compared to 24 and 27 for Finimuzumab. And as of now, January, 6 months back, almost of January, we have almost 660,000 patients treated with Eunumab worldwide. I think now we passed 700 already within this 6 months. So what type of world data is being published worldwide? So we have mixes of January 2022, this review of the all world data that was published. So in Eunumab, we have almost 74 or more of study real world data was published compared to Cakinizumab and Finimuzumab around 20. And this is affect the countries launched and the countries reimbursed because this is affect the study itself. So this map showing the countries that actually have this real-world data. And we can see it's arranged from Western country 2025 and then one country in each region. And we are lucky we have Dr. Alessandro with us. He published one real-world data that's published around 170 patients in UAE. So UAE we have our own real-world data experience, which is published by Medclinic in Dubai with Dr. Alessandro, our colleague today. So this real-world data was focused on effectiveness of the medication, safety and durability, physician perspective, and what patients, subpopulations that used or get benefit from the Eunumab or other CGIP. Also quality of life and functional outcomes, not only about number of days decrease, but how these medications affect the quality of life of the patient and how this affect the healthcare resource utilization. And this is very important topic or point for us who's a busy neurology clinic. and how's the dose and the route of administration between sub-Q or IV medications and others. Other route now we have oral, but it's stay not yet in the clinical or clinical experience. Real-world data, we don't have it for it because it isn't approval for the oral CGRP. So what is the real-world evidence and why it's important? So the real-world evidence is the clinical evidence regarding the use and the potential benefit or risk of a medical product, which is derived from a real-world data, from a real patient, from a real experience on a daily basis, not as a controlled study. So it's very important for all of us and for all the neurologists, for all the physicians to have a real-world data, because in most cases we have a different results from the real-world data when compared with the randomized controlled trial. And this real-world data is being collected and or the sources of some information, including, of course, electronic health records, patient-generated data as assay questionnaires, claims and billing activities from the payer or the man or insurance, product and disease registries. We have many registries that developed in the last few years, and data generated from other sources. We have now the mobile or electronic devices. We have many applications now that's used by some company to collect this data and by some physicians to collect this data and give background of what's the benefit of the medication, what's the efficacy, what's the durability, what's the side effects, and what is the persistence of the patient on the medication through this electronic application. If we want to compare between the real-world data and RCT, which is randomized controlled trials, that the medication gets approval based on it, according to the patient itself or the group of the patient, when we are talking about real-world data, we have the awareness of assess of the medical product in a more clinical diverse setting, in a more patient group, in different patient groups, comparing when we go to the RCT, assessing the medical product in a highly selected patient population with specific inclusion and exclusion criteria. Why? What we're using to assess the medical or assess real-world data is assess the medical product underlying conditions that affects the real use of the medication is actually daily practice, is actually clinical practice in your clinic, in your home. Why in RCT or randomized controlled trial, the product is only tightly controlled setting with a phone call every day, every other day, or whatever. So it's a different setting when you assess this. And regarding the outcome and the real-world evidence or real-world data, we're evaluating the long-term outcomes, safety, quality of care, and barrier to use, and even can extend into many years. And you have many contributing factors, social, health issues, so have many confounding factors that can affect this. While in RCT, it's evaluated the effect within a specific time frame. It's already extended into years, 5 or 7 years, but for the headache, most of the study who gets approved based on it, it's only extended for 6 or 12 months maximum. But 2 years or 3 years, it's too young for a study for headache medication to get approval with RCT. However, both real-world evidence or real-world data and RCT, randomized controlled trial, both are complementary and both complete each other. So both are able to define a treatment absolute value, and it's value relative to the alternative intervention, like other medications, like other procedure. And both real-world data supplement and complement the information which we gained from the RCT. So as in most of CGRP, we have a significant decrease in the headache days in the RCT, but it was not numerically high, but significantly, statistically significant. In real-world data, it's more higher benefit we are seeing all in our clinics regarding real-world evidence or data. So if we look to the effectiveness of the CGRP in the real-world data, real-world evidence, we have this study in NeuroMap in the high-frequency episodic migraine and chronic migraine, which is done in Italy in almost 400 patients, and they look for the response rate in the high frequency and response rate in the chronic migraine. This patient was taking 70 milligram NeuroMap once monthly, and the patient to enter this study has to fail at least 3 classes of migraine preventive medication. and it is 3 classes, not 3 medication. So if patient is taking antiepileptic, Topomax, and Tibaquins is considered as 1 class. So this patient may have 3, 4, 5 medications rather than only 3 medications. So this was a highly resistant patient to treat with migraine. And if we look here after 4 weeks, 8 weeks, and 12 weeks, we can see the persistence decrease in the headache days, either in the high frequency or in the chronic migraine days. Both show persistence decrease and even mild increase in this effectiveness over time. 4 weeks compared to 8 weeks compared to 12 weeks. And we have 50% responder, and we have 75% responder, and we have even 100% responder. And in all the responder yet, there was a persistence in the percentage of this patient who respond to these medications. Another ethnic group, which I know they are very obsessed with dechronification, which means you have a chronic migraine headache, they want to dechronification or elevation from chronic migraine to episodic migraine. As we have some neglected episodic migraine, which is chronification to a chronic migraine, they have the reverse alter for this. So they have this observational study in 155 patients, which started with a baseline of high episodic with chronic migraine, which means all the patients have more than 15 days of headache a month, and they follow for 6 months. And they see how many of these patients are converted to episodic migraine from chronic migraine. We can see almost 70% of this patient converted at months 4 to 6 to an episodic migraine, which means this patient has a significant improvement in their headache, monthly migraine headache, and they dropped some of them to low frequency from 0 to 3 days, some of them to low frequency, some of them stay in the high frequency. So this proves the efficacy of the medication in the chronic migraine and a short term of 6 months to dechronification of chronic migraine to become, again, episodic migraine, which is more easy or more tolerable for the patient. So there's another study which contained about 100 patients in Germany, which looking for effectiveness of ianumab in refractory migraine patients. And this refractory migraine patient has associated with around 66 or 2/3 of this patient will have medication overuse headache. So at month 3, almost 60% of this episodic migraine and 40% of chronic migraine has more than 50% reduction in their monthly migraine days. So they have a significant drop of their number of days per month. And 53% of them converted from chronic migraine to episodic migraine, again, dechronification. And comparing a 66% of this patient when start was have migraine overuse headache, at the end of the study, this percentage from 35 increased to around 47% of this patient have no medication of use headache, which also showing a good number of treatment of medication of use headache with this medication in a world evidence. Also for chronic migraine, we have some evidence or real-world evidence about ianumab is effective in the patient who have failed botulinum toxin A, which is approved for chronic migraine. We have some studies which was published recently in the Journal of Headache and Pain. There's 2 studies showing here. Anyone can go back and open access for it. It's available for them to see how the ianumab after failure of Botox improve in the pain, medication use, and quality of life in this patient with chronic migraine. Let us go now to tolerability of CGRP monoclonal antibody in the real-world evidence. This study was done in Canada, and it have a huge number of patients, around more than 14,000 patients, and it is about ianumab treatment persistence. 83% of this patient was woman, and 17% was male, and the mean age was 47 years old, and the chronic migraine in this group was around 66%, which means this patient group is highly active headache group. So around 71% of these patients, which is 14,000, persistent to the ianumab after 1 year from treatment initiation. And 60% of them was shifted or escalated from 70 milligram to 140 milligram within 1 year. And this is the beauty of ianumab actually. You have some flexibility in the dosage. So you have 70, you can start it for 3 months to see how effective if the patient have low frequency or medium frequency episodic migraine, you can start with 70 and evaluate the patient after 3 months, see what's your target, what's the improvement percent, and you can continue on 70, or you can shift him to 140 milligram, and it's the same cost because 70 is the same cost of 140 milligram, and it's the same safety issue even. What about if we have someone interrupting the treatment due to any evidence or any event, insurance, or he get outside the country or something? Does we have an evidence for the persistence of the effect of the monoclonal antibody after discontinuation? Yes, we have this real-world data coming from Switzerland. It's a small number of patients, around 52 patients, but it's a real-world. And data was analyzed for patients with episodic or chronic migraine with a monthly injection of CGRP for 12 months. And it's collected from 5 different centers over Switzerland. 90% of this group was female, compared to almost 10% of women aged from 48 to 60, or 48 plus minus 12 years old, and patients with a chronic migraine, again, in this group was around 40%. If you can look to the table here, this is the migraine test at the baseline, and this is how after 3 months it decreased from 14 to 6, from 20 to 7, and so again, after 12 months to 5, and to 5 was almost average of 75% responder rate. And after interruption of the treatment in the first month, second month, there was still a good response, but it tended to increasing again until the third month, which is considered as the 3 months period. You can stop and see how the effect of the new treatment on the migraine after 1 year, if you want to stop the medication. However, once this patient has the headache again, and then we restarted the medication again, we have immediately the good effect immediately from the first month, which means this patient can take whatever drug holiday, or if it's missed due to some issue, this patient can improve again or responding again with the same rate of response if you reinitiate the treatment again. What about medication overuse headache after treatment cessation? So in this study in Italy, almost 200 patients, all patients had a chronic migraine, and all of this patient was complicated with migraine overuse headache at the beginning of starting NeuroMap for 1 year, 12 months. And they assist 3 months post-treatment discontinuation. And we can see here, at the end of the 1 year, there was significant decrease of the medication percentage of the patient with headache and suffer from medication overuse headache. And after we stop the medication, as expected, there's an increase in the percentage of the patient who are getting every month more headache. However, at month 3, only 18% of this patient has medication overuse headache compared to a higher percentage before starting the medication. So still, we have, after 3 months, even still a good response, but it is increasing with time wearing off the medication after stopping the medication, of course. What about switching? Do we have an evidence for switching between our CGRP monoclonal antibody we have now, NeuroMap, Glucosamine, Fiminosamab, Eptinezumab, recently we have the ORG bands even. So do I have evidence for shifting between patients who are not responding to one of CGRP to others? This study was done in Germany, small number of patients of 25, because we don't have this reward or daily brackets of shifting patients from one to other. So it's a small number of patients because of this. And all of these patients was analyzed who didn't respond to NeuroMap, shifted after 3 treatment cycles at least to receiving Fiminosamab or Glucosamine, almost 50%. And it's only, you can see here, only 12% of this patient achieved more than 50% response. So it's only a chance of about 10% if you don't have a response to NeuroMap to have a response with other medications, which is usually because all of them working on the same mechanism, but by a different way, as a receptor antagonist or ligand antagonist. So NeuroMap is a receptor antagonist, so it's the same at the end you attack the same molecule. So if you fail one, it's unlikely to be responding to another one. What about hormonal? What about insulin-related migraine? Does we have evidence? Yes, we have evidence in this ETA group. We have this patient who have a high frequency or chronic migraine patients with menstrual-related migraine, and this is a 40 patient in Italy with a worldwide data, and we can see in the graph here, this is how much the menstrual migraine days was dropped after starting the medication by 6 administration or 6 months, and also after the chronic migraine itself, the number of the days. So menstrual migraine days were reduced from median frequency of 5 days at the baseline to 2 days, which means around 60% improvement in the number of days. And also the duration of this menstrual migraine attacks were reduced from a median of 24 hours to only 8 hours. Pain intensity also was reduced from 8 to 6. So we have many factors that improving, not only the monthly migraine days, it's the duration and also the pain intensity itself. What about the patient-reported outcome and the patient quality? So this is a study showing that 155% treated with Inumab has more than 70% of this patient with less than 50% monthly migraine day reduction, and 62% of the patient with more than 50% of monthly migraine days reduction showed improved in intensity of the pain, which means we in the clinic, when we sit with some patient, we have to put a target for his medications. So we should discuss with the patient that this medication is not concerned only with the number of days of headache per month. No, even if you have headache, the pain of this headache attack will be yes, not only the pain, the duration will be yes, not only this, even the symptoms, the aura, the severity of the pain, and the response to analgesic even will change. This is how I'm basically doing in my clinic, and doing in my one hand, number of days of headache, severity of headache, severity of the headache if it comes, duration of the headache, symptoms of the headache, and the response to analgesic. So all of these are target for the patient when you talk to the patient, and this is the evidence we have. We have now a little bit small review about the first head-to-head study in medication regarding the anti-migraines. So this is the Hermes study, which a head-to-head study of Inumab against Tubamax, which is a class evidence one for migraine treatment to assess durability and efficacy in a patient-centered setting. So what's Hermes study? It's a first head-to-head study, as we said, comparing Inumab to standard of care of with Tubamax, and it's designed to assess the treatment efficacy, which including durability and efficacy. And also it's done in Germany with around 800 patients in 82 sites with episodic and chronic migraine patients. It continued for 24 weeks, and it's conducted between February 2019 and June and July 2020. Our primary endpoint was about treatment discontinuation to adverse effects. We have many secondary endpoints, 50% reduction in monthly migraine days over the 3 months, which is the second half of the 6 months. Exploratory objective, which reduction in monthly migraine day over the last 3 months. Functional impairment, which is measured by HED6, and quality of life measured by SCF36 version 2. Here, the patient characteristic was around 85% woman, 14% male, around average age 41 years old, 22 years since disease onset, which means they have a very long history of migraine days, and around 10 days average monthly migraine days. And both group of patients, as in the placebo treatment group, or it's not placebo, it's a Tubamax and the treatment group, both of these patients was receiving a daily tablet, which is Tubamax or placebo, and also receiving an injection every 4 weeks as a Inumab or placebo. So both arms taking the same medication exactly. Sorry. And the patient were classified depending on the number of days of headache per month. So your frequency from 4 to 7, median frequency 4 to 7, high frequency 8 to 14, and chronic migraine. We have around 60% of this patient naive to any treatment, prophylactic treatment, 1/3 receiving before 1 medications, and the other 10% was receiving 2 or 3 medications. So regarding the primary endpoint, we have almost 40% of the patient on Tubamax discontinuing the medication within 6 months, compared to only 10% in Erenumab, which means almost 4 times more patients discontinue with Tubamax due to adverse events compared to Erenumab. So it is the side effects who make the patient stop these medications. And for the second endpoint regarding the response rate, we have almost more than 55 compared to 30% or 31% responder, more than 50% responder rate, which means 2 to 3 fold is more likely to reduce migraine monthly days by 50% or more in the patient taking Erenumab versus Tubamax, which is a standard of care for all of us for the last 20, 30 years. For the other exploratory endpoint, which is a head impact test 6 is a change, or this is measures the quality of life. So the user number is the good quality of life. So we have more reduction in Erenumab in the head score, almost even compared to almost 8 in Tubamax, which means patients receiving Erenumab report significantly larger reduction in head 6 score versus Tubamax, which means more better quality of life. Even for the safety, if we go to the emergent adverse effects or serious adverse effects, so to Erenumab, we have only 215 patients who have some adverse effects, any reported adverse effect compared to 315, which 55 to 81. Among of this, only 10% in Erenumab see side effects leading to discontinuation of medication, compared to almost 40% in Tubamax. That's sorry for this. For the study related severe or serious adverse effects, only 1 patient in Erenumab compared to 2 patients in Tubamax who could have serious side effects in this study. So the safety study giving us that Erenumab demonstrate a good safety profile, which is similar to the previous study, which is a controlled or randomized controlled study and other real-world data. A new safety event was observed within the Hermes study. No any new safety event or serious side effects was emergent that need any new awareness or any new mention to our patient. By this, I end my talk. I hope I success in it, and I am open for any question.
Thank you, Dr. Ali, for a very enriching presentation. And yes, allow me to take some question. So I would like to ask our audience to type their question in the Q&A session, so Dr. Ali can answer all of them. So the first question, you talked about the real-world efficacy and safety of Erenumab, and someone would like to ask you, where do we place these anti-CGRP therapy in the guidelines, in the treatment guideline of migraine? So should the patient fail one or two options before shifting them, or can we initiate a naive migraine patient on these medications?
So thanks, Mara, for this excellent question. So this is a daily practice for all of us, and a very important question. So the international guidelines, as American headache guidelines or European guidelines, was advised only to shift to monoclonal antibody after starting or after failure of 2 other medications. This is for episodic migraine, with at least 2 to 3 months trial. And for the chronic migraine, it's better even to be after Botox, so 2 oral and 1 Botox. However, this recent, just within the last few days, there's a change in this in some of European countries that it will be allowed to start to the naive patient. However, this should be individualized. Like we have in UAE here or in the Middle East, we have many patients who are non-compliant to the medications, have more multi-therapy because of other diseases, has his job does not allow to him to take some oral medication like Bariot, or some patient who are working in the army, have many traveling a day every week. All this patient is not fit for oral medications. So this GIP is an amazing for all of this as a naive. We have many naive patients in UAE, and they are showing amazing results actually.
Another question, what are the absolute contraindication of initiating a patient on erenumab?
Only hypersensitivity. This is the only absolute contraindication. Non-hypersensitive to erenumab or to IABAR, because erenumab containing IABAR in the injection bin. This is only two absolute contraindications. But we have some precautions. If the patient have some constipation, have some high BP, then we have to be a little bit cautious with this and follow up or informing the patient at least. This is how we should monitor this.
And Dr. Ali, here come a question that just crossed my mind. So if a patient develops severe constipation on erenumab, what would we do? Do we stop the medication temporarily and then we re-challenge the patient with erenumab, or we discontinue permanently the medication and we shift to another class of medication?
So to be honest, I used erenumab in more than maybe 100 to 100 patients now since 2018. I never have any single patient with constipation. But always we are talking about this, it's less than 1% chance of having it. But we have to ask the patient about what his baseline before starting erenumab, because many of these patients with headache especially have a chronic constipation, especially when you're using some medication like diacyclic for the migraine itself, which is causing this constipation. So if the patient has severe constipation, I will not change him again. In the background, we have many options now, to be honest. But it's not, I never saw it, but it is there. We have to look for it. We have to ask our patient about it at the baseline and in the follow-up later on.
Another question, what is the safety of erenumab in pregnancy? Do we have experience about the use of erenumab in pregnancy, or do we have pregnancy registry for erenumab? What is the current data or evidence?
So for evidence, it's contraindicated. It should be stopped 3 to 6 months before planning pregnancy. This is because we don't have a data. We expected this will be changed in the future, but now we cannot recommend any patient who take any monoclonal antibody to get pregnant, except if she stopped, even in some reference up to 6 months. But usually 3 months will be enough for me. Yes, you can't now many registry for all different monoclonal antibodies based on the companies, which is correcting data, because many of these patients get pregnant accidentally or incidentally while they are erenumab or other monoclonal antibody. They now don't have signal or sign for issue, but still it's too early to conclude anything of this. So it's contraindicated.
Just allow me to comment here that from a pharmacologist's point of view, I think that monoclonal antibody have a large molecular weight, and most likely they will not cross the placenta and will not cause damage to the fetus. But of course, we have to wait the result of the registry, the pregnancy registry, or more clinical trials or clinical studies data, of course. But theoretically, like all the monoclonal antibody that we use in MS, they do not usually cross the placenta. So another question, what to do after the patient fails one CGRP? As you mentioned, there is a low chance to success on other CGRP. So if a patient fail on a first CGRP drug, what is usually the strategy? Do you challenge him with another anti-CGRP, or you shift to another class of medication with different mechanism of action?
So first question I have to ask myself or anyone in the clinic, ask if the patient failed CGRP, does this patient have a migraine headache or other type of headache? Because it's the success rate is very high with CGRP. And shifting from erenumab to others or from others to erenumab has some evidence. I have some patients who responded to this and not responded to others, but it's a low chance. So first I will change myself, since the diagnosis is correct or no. Then I will ask the patient, because as we know, migraine has a multi-confounding factor, multi-contributing factor, like food, sleep hygiene, coffee, stress. So I have to ask about all of these factors, if it's well controlled or not. I have in my clinic one of the earliest, I have to say that I don't know, but I have to say that one of the first clinic used Botox with CGIP in the world was at our clinic, because this was a challenge for us. We have many patients who have a chronic migraine headache and will decrease from 25 days to 10 days. So we're very happy, but still suffering. So when we have CGIP coming, we combine both, and we have an amazing result. Both of them working synergistically very well. So if this patient have a chronic migraine, I may add another class, including products or even oral medications. It depends on that. But the first question, does this patient have a migraine or no? Second question, does this patient follow your instruction in daily activity lifestyle or no? Then you think about the medication. It's number 3, not number 1 in this patient.
And the final question, from your experience with the use of anti-CGRP therapy, what is the most cause for discontinuation of this medication? Is it side effect? Is it efficacy? Is it a lack of awareness from patient, or lack of knowledge about anti-CGRP, or a drug that did not meet unrealistic goals, unrealistic expectation from the medication? So what is the rate of discontinuation of such medication, and what is the major cause for discontinuing such drugs?
So the major cause of discontinuation of this drug in my clinic is the efficacy, which means a high efficacy. It's not high efficacy. So some patient takes some medications for 3 months, 6 months, because my clinic is busy. I'm not seeing the patient on a monthly basis. So he takes some medication 6 months from the pharmacy, and then after 6 months, so it's a B. And come after another 3 or 6 months, why you didn't come? I was amazing. My headaches went away. Why I should come and take it again? Then I discussed with him again. You must continue at least 1 year, and then we see with time what we do. So the high efficacy is the most problematic for me in my clinic, to be honest. But we have some patients who's not responding. This is 2 to 3%. We think this patient have another type of headache. Reimbursement sometimes an issue for some not high insurance company. We have some issue with patients. Side effects, I don't remember till now in my clinic was more than 200 to 300 patients on monoclonal antibody. Some of them would stop some medication because of side effects, especially injection site reaction. If you educate your patient way about the precaution, how to use the medication, and how to keep it out of reach for 30 minutes before you give, you will never have this as a big issue, especially it's 1 injection every 28 days. It's not on a day or weekly basis. So whatever side effects will be the answer if side injection site reaction. Constipation, I never saw any patient, to be honest. But efficacy.
And yeah.
Right. Ask.
So talking about the efficacy and high efficacy of this, or very good control of erinumab for migraine attack, do we usually, or do we have data, or do we have any recommendation for discontinuing erinumab after a certain period of time? So should the patient take it for life, or if his, of course, migraine is well controlled and is free of attack for 1 year, do we have data about discontinuing the treatment, and when to discontinue erinumab?
So data for recommendation of discontinue medication for migraine headache, all over, we don't have this evidence of data. We have some recommendation that if the patient is continuing medication for 1 year and they have more than 75% or 80% improvement of headache and his quality of life dramatically changed, you can, after 1 year of achieving the 3 to 6 months good quality of life, no major headache, reduction of the headache days, then you can stop some medication and you change him usage. As we show in the real data, so some patients who kept for 3 to 4 or 5 months without headache, and we have some patients who take unification, which means high frequency or chronic headache become low frequency headache 1 or 2. It can control it with PRM medication for 1, 2, or 3 years. This is for the migraine as a whole managed plan. But we don't have recommendation. We want to stop it. But some patients who is difficult to treat should continue on this medication for at least 2 to 3 years, and then you change your life and see what will happen with this patient if the headache will come back again. We have a specific other medication like spacing in Botox, because you can spacing the medication, but we don't yet have this in erinumab because of a small number of years we have experience. But maybe in the future, instead of stopping some medication, we will spacing instead of
space it.
take it 5 weeks, 6 weeks. This is my personal expectation. It's not a recommendation, but this is,
yeah, of course.
Not to take it as a recommendation. This is my personal expectation. I'm not doing it even now because of very limited data of 4 or 5 years. It's not enough for us to consider it.
Yeah. I will take a final question because we don't want to delay Dr. Alessandro further. So if a patient has concomitant depression with his migraine disease and he is maintained on antidepressant medication, if there is any contraindication or drug interaction between the Erenumab and antidepressant medication, or can he take them both?
So Erenumab is almost have no drug interaction with any other medication until now. So the history of drug interaction for all CGIP is very minimal, and this is one of its beauty. Even it can be given with another monoclonal antibody for other diseases. There is no any contraindication or any drug interaction. So it's a very safe, very tolerable, and there's almost no drug interaction with any antidepressant or most of other medication, 99% we are using on a daily basis.
Thank you, Dr. Ali, for being with us tonight and for answering all our audience questions and for an excellent presentation. So we'll move now for our second lecture and second speaker. So our second migraine specialist is Dr. Alessandro Teruzzi. Dr. Teruzzi is currently the head of the neurology department at Mediclinic City Hospital and clinical lead and head of Mediclinic Comprehensive Stroke Center at City Hospital in Dubai, UAE. Dr. Teruzzi graduated from and underwent specialist training in neurology at the University of Medicine and Surgery of Milano in Italy, where he also obtained a second-level master degree in cerebrovascular diseases. He was working at the neuroscience department at Manzoni Hospital as a stroke neurologist, where he was the former director of the Headache Center before moving to Dubai in 2017 as a consultant neurologist. He's also a well-trained neurosonologist, expert in ultrasound Doppler investigation of the carotid and vertebral artery and transcranial echo color Doppler. Since 2019, he collaborates with the Mohammed bin Rashid University as adjunct clinical associate professor. Dr. Teruzzi's primary interests are the diagnosis and treatment of headaches and cerebrovascular disorders. Dr. Teruzzi will share with you real-world clinical cases from his headache clinic for discussion. So I would like to encourage our esteemed attendees to actively participate in our case discussion session by voting to the poll. Dr. Alessandro, we are always honored to have you as a speaker with us. Please start your presentation.
Dear Dr. Maya, thank you for the nice introduction and the very kind words. And thank you also to the organizer for inviting me here tonight, and all to all the audience for being here so late in the evening or maybe so early in the morning, depending on your time zone. So without any further ado, let us go through the few cases that I selected for tonight's presentation. This is my disclosure of interests. And this is case number 1. You're all very familiar now with monoclonal antibodies and Erenumab after hearing the amazing lecture from Dr. Ali. So let's give a look at the case number 1. It's a female, 41 years old of age, with obesity, BMI 30. She's a mother of 2. She works in a bank and she has a very sedentary life. She has a strong familiarity for headaches from mother's side. And she has as comorbidities dyslipidemia and diabetes type 2, which are well under control, but still under medication. She doesn't work and she doesn't drink alcohol. So about the pattern of her headaches, what she reports, she refers suffering from one quite strong, moderate to severe headache per week with a visual analog scale intensity of 7 out of 10, with a throbbing, pulsating pain that usually hits her temples on both sides at the same time, with nausea and vomiting also, and strong discomfort from bright lights and loud sounds, as we call photophobia and phonophobia. Overall speaking, she can refer 3-4 of these quite strong disabling headache attacks per month. The headaches are quite bad and quite severe, to the point that she refers performing poorly at work when there is an ongoing headache attack. She can go to work, she doesn't have absenteeism, but her productivity is reduced. Not only, but she's also referring that she has missed in the past family gatherings or events, school shows, for example, from her kids because of the headaches. She also referred further investigating, because it's very important, you always ask more and more questions to your patients, that she also is having milder headaches, and not as bad as those ones that she immediately reported to us. She also have milder headaches, 4 or 5 of severity, that are more spreading from the back to the front of the head. They can be in switching sides, sometimes they're on the right, sometimes they're on the left. There is mild nausea and there is mild photophobia. Usually they last a day, half a day, no more than half a day or a day of duration. And she can experience 1 to 2 of these episodes per week, so 4 to 6 of these episodes per month. So keeping in mind this kind of pattern, I would like to invite you to go for a possible diagnosis for this patient. So we'll have a poll. Would you consider this a case of migraine without aura, a case of tension type headache, a case of cervicogenic headache, or a case of chronic migraine? If you have to pick up and choose one of these answers. I will give you now some time to vote in the poll. And then we will see the results and we can discuss case by case your diagnosis or possible alternative diagnosis.
So I would like to ask all our attendees to vote. We'll give you like 6 seconds for each question to vote. And then the result will show up on the screen.
Results are now shown.
Okay, so I would say that we have the majority of the attendees splitting between migraine without aura and chronic migraine as the 2 more probable or fitting diagnoses, and a few said the cervicogenic headache and is more a percentage of tension type headache. Okay, so let's see the diagnostic criteria as per the International Headache Society revision 3 of the guidelines published on cephalalgia. The criteria of migraine without aura that we know are at least 5 attacks lasting 4 to 72 hours, at least with 2 or more, either unilateral, pulsating, moderate to severe pain, aggravated by physical activity, and at least 1 or more of nausea and vomiting or photophobia and phonophobia. And we can, looking at the pattern of the attacks of our patient, definitely the stronger attacks are fitting this criteria. Tension type headache, more attacks with short duration, 30 minutes or longer duration up to 7 days, with 2 or more of bilateral pressing quality, only mild to maximum moderate and not aggravated by routine physical activity, and both of no nausea and no photophobia or phonophobia. Cervicogenic headache is a little bit different subtype of headache because you should have evidence of some kind of disorder or lesion in the cervical spine or the soft tissues of the neck to potentially be the cause for headaches. And at the same time, you should fulfill 2 of the criteria, like headache developing in temporal relation with the onset of the cervical disorder, improving or resolving after resolving the cervical disorder, and with a reduction in the range of motions of the neck, and headache abolished by diagnostic block of cervical structures. So even if the headache of this patient was coming from the back from the neck and spreading to the temple, to the eye, we do not fulfill the criteria for cervicogenic headache, nor the criteria for tension type headache, even if she was reporting a bilateral, not so strong pain. And not chronic migraine, because the frequency, the numerosity of the attacks doesn't fit the criteria. For chronic migraine, we should have a history of at least 3 months, consecutive months, with more than 15 headache days per month, with at least 8 strong migraine attacks among those 15 headache days. So even her milder attacks actually are still fitting in the migraine without aura pattern. If you look at her headache diary, we can see with the circled, I reported here just a sample of one page of the headache diary of the patient. She was reporting 4 strong attacks. We categorize attacks: 1 when is mild, 2 when is moderate, 3 when is severe pain, and another 4 attacks of milder pain. And we also collected the number of painkillers she was taking. So we can see that she does not fulfill the criteria for chronic migraine as well. So diagnosis for this case is migraine without aura. Actually, the disability, level of disability coming from her migraine is quite high. She was scoring 22 at MIDAS. MIDAS, as you know, it's a self-reporting questionnaire for disability coming from migraine, and is divided in 4 grades: 1, 2, 3, 4. 4 is the most severe kind of migraine, and she was hitting the threshold for grade 4, so severe disability from her migraine. She tried already in the past topiramate, but she didn't tolerate it well because of the cognitive side effects. She was having memory problems and word findings problems, and she couldn't manage the proper therapeutic dose. And what other treatment options we could consider for this kind of patient? So we'd like to invite you again to go for the poll, for voting, which prescription you would probably offer for this patient, female, with disabling episodic migraine, who already failed on topiramate, with obesity, diabetes, and dyslipidemia as comorbidities. I will leave 6 to 10 seconds for voting for the poll.
5 seconds to go. Okay, I'll stop the poll.
Okay, hopefully. Okay, very, very interesting. I would probably agree with the attendees. So the 2 most voted and recommended medication would have been, for this case, erenumab every 4 weeks, as we know, or amitriptyline, and there's very small percentage voted for flunarizine and propranolol. I would say that I agree with these 2 options. Looking at her case, since she's having obesity, definitely flunarizine is not a good call. Amitriptyline could be, so I agree. On small dose, explain to the patient that she could experience a little bit of increase of the hunger sense, but usually is not dramatic. Could have been considered. Flunarizine, I would say no, because flunarizine does really push on the hunger centers, and for obese patient can be a disaster, even for a limited period of time. But beta blockers, propranolol, no, because being a beta 2 and beta 1 receptor blocker, working on the beta 2 will increase and make worse delay response to hypoglycemia, becoming potentially problematic for their blood sugar management and all the symptoms coming from hypoglycemia. So we decided to go for erenumab. In this case, we decided to start straight away with 140 milligrams every 4 weeks. As you know, and as was discussed also before, there are 2 doses available for erenumab, 70 milligrams and 140 milligrams. We decided to go for, with the patient, to go straight away for 140 in this case, because the disability was really high. Frequency was not dramatic, but the level of disability was very high, and we were trying to have the fastest possible response and onset for this suffering patient. So we started Erenumab, and the first month, usually we do 1 month follow-up, and then 3 months and 6 months follow-ups. So the first month, after starting Erenumab 140, she already reported a quite consistent improvement. She was having a headache diary, only 1 strong migraine attack per month, and 3 milder migraine attacks per month. Still reporting occasionally nausea, but no more vomiting as before. And this is probably the most important achievement in the very, very first month, was no more functional loss. So despite having residual migraine attacks, she was functional, and she could attend her tasks and duties at work or family needs without any further limitation. At the follow-up visit in month 3, she was showing a 75% reduction in the monthly migraine days. She was pointing out at the headache diary only 1-2 migraines per month of much, much milder intensity, now easily responsive to simple painkillers or occasionally using triptans, and no more most bothersome symptoms, nor functional loss. So she was perfectly functional and free from nausea, photophobia, phonophobia. 6 months visit confirmed the same level of satisfaction. She was still having more than 75% reduction in the monthly migraine days, no more bothersome symptoms, and basically managing 1 or maximum 2 milder headaches or migraine per month. And the most important thing, no side effects, no complaints, excellent tolerability, coupled with excellent efficacy, I would say. If we want to have an interactive discussion, we can have a question and answers session at the end of the case, or we can keep them for the 3 cases. At the end of the 3 cases, we can review the most important characteristics at the end. You are free to open the Q&A session with a chat box if you want.
Let's keep, Doctor, the question till the end, please.
Perfect. So last poll for case number 1, duration. So we have heard interesting data from Dr. Ali lecture. So what should we do for this patient? We keep her for 6 months of treatment on Erenumab 140, and then we stop, assuming that she keeps doing well as she's doing now. We keep her for 12 months on Erenumab 140, and then we stop. Or we can do something intermediate. We give her 6 months of full treatment, then we can try to taper it down for 3 months on 70 milligram only. And if she keeps doing well, we can stop. I would like to invite you to vote after also receiving the new data from Dr. Ali's lecture. And then we can see your answer. Here, there is not a right or wrong answer, actually, because we don't have final or finalized data yet, but it would be interesting to see what is your call on this. Let's see the results. Okay, so 65% of the attendees are suggesting to keep her for 6 months on the full dose, and then to try to taper down for 3 more months, for example, to a smaller dose of 70, and then stopping. 22% keep her for a year on the full dose, 14% try to keep her only for 6 months on the full dose and then stop. As I was saying, there is not a right or wrong answer. I would probably say that I would rather keep her for longer than for shorter. So probably not 6 months only of treatment, because we did this for several years and it doesn't pay off. They fall back having migraine quite soon after interrupting. So we'll probably be in favor of 12 months of treatment, or 6 to 12 months of treatment, and then tapering down to 70, and then after 3 months on 70, trying to stop it completely. Okay, so I would like to introduce now case number 2. Case number 2 is a young woman, 28 years of age. She's an expat. She has a BMI of 18, so she is definitely skinny. I would say borderline for anorexia. She's not married. She has a boyfriend since many, many years. She graduated in finance and she's attending an MBA. Familiarity for headaches is quite strong from mother's side. She's very healthy and super sporty, super fit, very careful about what she's eating, exercising every other day. No smoke, only occasionally alcohol, social alcohol, drinking quite a lot of coffees, 6 to 8 coffees per day, Americanos, and double espresso shots. And she has a very stressful, hectic life because of her age, because of her MBA and their working and social life activities. So about this young lady, she was referring 1 to 2 very strong headaches per week with a visual analog scale of 8 out of 10, with throbbing, hammering, orbital or temporal lateralized pain, with strong nausea and vomiting, and with strong photophobia and phonophobia, and also osmophobia, actually, over at least 1 day, 1 full day of duration. She was referring 6 attacks per month. Some weeks she could have had 2 attacks. Some weeks she could have just 1 attack. Usually the time of the month close to her menstrual cycle was always harboring 2 attacks, usually one close to the other. And she learned that to function, she had to overload herself with painkillers and medications because a simple analgesic was never enough. So she was basically taking 2 paracetamol tablets at the same time, together with 2 ibuprofen tablets at the same time, of 400 or even 2 of 600, together with 2 paracetamols. And she was also reporting just sporadic milder headaches, once in a week of a mild headache, more widespread, but still with nausea and photophobia of 1 to 2 days of duration, typically on the weekend, still mildly throbbing and hammering, but definitely not as severe as the other attacks. So she could totalize 3-4 of these milder throbbing with nausea and photophobia headaches, typically in the weekends. So again, I would like to open the voting session for the diagnosis, considering the frequency of their headaches, the severity of the headaches, the amount of medication. We have to focus if it could be a migraine without aura or a tension type headache diagnosis, if this can be medication overuse headache, or if this can be chronic migraine.
Okay, 5 seconds to go.
Let's see now in a few seconds the results from the attendees.
Okay, I'm stopping the film now.
Here we go. Okay, interesting. But I agree, because of course now we have only limited information. So when you are face-to-face visiting your patient, you can make many more questions and you can try to have a more accurate diagnosis. Sometimes the patients, they will report you some symptoms, they will try to take you in one direction. And if you don't lead the clinical discussion properly, they can mislead you and you can end up with the wrong diagnosis. So we have majority of the colleagues are in favor of tension type headache. And then you've got a head-to-head between medication overuse and chronic migraine, and only a small percentage diagnose migraine without aura. So here is important to review the criteria for these 4 categories of headache, because it's very important to make the right diagnosis to later on provide the right treatment. We'll always remember that looking at the criteria for migraine, you have 2 or more, but not all of them. So should be either unilateral or pulsating or moderate to severe or aggravated by physical activity. In her case, not aggravated by physical activity, at least she never reported that, but she has moderate to severe pain, yes. It's pulsating, yes. And it's unilateral, yes. So she's fulfilling most of the criteria for migraine. And she's also reporting as criteria D, nausea and vomiting and photophobia and phonophobia. if you look at tension type headache, which met the favor of 25% of the attendees, you have high number of headaches of very variable duration, 30 minutes to 7 days. She never had such shorter or such longer attacks, such long attacks. Bilateral pressing or tightening should be usually described like a heaviness, like a pulling, like a heavy helmet sensation. Only mild to moderate, never reaching high severity and not aggravated by physical routine, and both of no nausea, vomiting, no more than one, only photophobia, phonophobia. So again, she's not fulfilling the criteria for tension type headache, but she's not fulfilling the criteria for chronic migraine again, because you need to have at least more than 15 headache days per month. She doesn't reach 10 in monthly migraine days. And among these 15 days of headaches, at least 8 must be fully diagnosable as migraine attacks for at least 3 consecutive months. Medication overuse could have been an interesting option because definitely she's taking a lot of painkillers, but medication overuse has very specific criteria that you have to fulfill to diagnose this condition. You need to have at least 15 headache days per month in a patient with a history of headache, of course, and migraine, with regular overuse for more than 3 months of one or more drugs, categorized as more than 10 days per month for more than 3 months of triptans, for example, in this case, and more than 15 days per month for more than 3 months in a row of painkillers, analgesic, anti-inflammatory medications. So basically, you need to have at least 10 or more triptans per month and 15 anti-inflammatory or more per month for more than 3 consecutive months, and at least 15 headache days. So let's see. Looking at her headache diary, we can see that we have less than 15 headache days per month. She's having 3, 6, 9, 10 episodes. One is a continuation. And she's taking several painkillers. This is true. But if you look at the amount of medications she's taking, she never tried triptans, and the amount of analgesics she's taking for single category doesn't reach 15. As a combination, yes, they do, but you do not have the number of headache days and the duration sustained in time. But if she's at risk of medication overuse, I would say absolutely yes. So it's not a completely wrong idea. It's absolutely relevant to become, because she will definitely become overuse headache. So diagnosis will be again migraine without aura, high frequency, -17, grade 3. So she's having partial disability. So it's moderate disability, grade 3, because she is killing the migraines as quickly as possible with a quite strong dose of painkillers. She's a naive patient, so she never tried specific prophylactic medications. And this could be interesting to go for the discussion of which prophylactic treatment we can offer to this young patient. So again, remembering the characteristics, she's a young patient with very low BMI, borderline for anorexia, naive to medication, very sporty, very concerned about her physical appearance, training every other day in the gym, running and doing all kinds of sports because she's really focused on her appearance. But she's also working very hard and studying a lot, having excellent results at work and higher education, with a very hectic life and heavy coffee drinker. So let's see how this will. A few more seconds to see the results.
I'm ending the full motion.
Okay, interesting. This is I think it's a nice case to discuss. Again, there is not a single right or wrong answer. Of course, it's a case-by-case decision. We have to discuss treatment options with the patient, she need to be compliant. You need a therapeutic alliance with the patient. Otherwise, you will lose her or him at the follow-up. You have to discuss, explain, and be sure that he understands, he agrees, and then you will be working together. Whatever medication you are offering to the patient, we will go through the side effects if it is necessary. So looking at your choices, lifestyle changes, 31%, totally agree. I'm a big fan of lifestyle changes and paying attention to quality of life as a result, but as also risk factors for or triggers for migraine. Propranolol can be a good option, I agree. Flunarizine, only 8% of the patients. I would say that on the paper could be an excellent choice because probably she could only benefit from a few more kilos, but it will be difficult maybe to have her on an agreement on this molecule. Erenumab is a good option, absolutely yes. Topiramate, 14% of the patients. I would be, I would be a little bit careful about using topiramate in a patient with a very low BMI because as we do know, topiramate has a very strong pro-anorexic effect and can really kill the hunger sense. Most of the patients, they lose 3 to 5 kilos on topiramate, on full dose at least. And this can be potentially triggering dramatic conditions in patients with already anorexic or borderline eating disorder. So this I would be very careful to prescribe this kind of patients. Because of their physical appearance and underweight, skinny body type, she would never have accepted flunarizine or amitriptyline, which on the paper instead could have been excellent options. So I would have kept them as possible good options, but she would never have accepted them. Beta blockers are also a good possibility, but we also have to consider the kind of environment we are living in. So we live, as you know, in very, very hot weather-based countries. And this patient is very sporty, very, very physically active, with a quite low heart rate as a baseline, spending a lot of time doing sport activity outside under the heat. And beta blockers could represent a potential problem for bradykinesia, low blood pressure, and also because can induce a quite striking depression of the libido, affecting also the private life of our patients. So we have always to consider this, not only in males, but also in females. So for her, the decision at the end of the day was to go for erenumab 70 milligrams every 4 weeks. We decided to start with a standard dose because of her very, very skinny constitution and because she was a naive patient. So we decided to couple, of course, a good coaching session about lifestyle changes, as most of you pointed out, absolutely relevantly and absolutely agreed, not to skip breakfast and not to skip meals, which of course was quite common for this kind of patients. Not oversleeping over the weekends, because probably her weekends headaches were due to the catch-up sleep she was having, sleeping late in the morning, basically, after having maybe quite interesting or wild weekend night, and to reduce the caffeine intake. So looking at the outcomes, 1 month follow-up, she improved, reporting only 2 strong migraine attacks per month, and 2-3 milder migraine attacks per month, and occasionally nausea. At 3 months follow-up, she reported 75% reduction in monthly migraine days, with only 1-2 mild migraines per month, so excellent response, and no more bothersome symptoms nor functional loss. 6 months confirmed 75 to 100% reduction. Not every month is the same. She was showing at the headache diary, some months with 1, some months with 0, sometimes with 2 migraine attacks, but basically very, very mild, 0 to 2 headaches per month each month, and no more bothersome symptoms. Again, absolutely no side effects and no relevant adverse events to report. Duration, I will open the last polling session for this case. 6 months on 70, which is basically the same discussion we had before for the first patient. 12 months, full year on 70, or plus 6 months on 40. So we give her 70, and maybe we decide to increase to 140 to see if we can improve even further her frequency of migraines, maybe bring it completely down to 0. Let's see the results.
5 seconds to go. Okay, now I'm switching the phone.
Okay, so 54% voted for Erenumab 70 milligrams for 6 months and then tried to stop, 30% to give it for a year, and 14% were considering escalating the dose after 6 months for another 6 months. I would probably agree with the choice of keeping her for at least 6 months on treatment. Can be discussed maybe for longer, but I don't see the need to increase to 140. She was already responding in an excellent way to the 70 milligram dose. I would keep it for 6 months and then try to discuss with the patient, being naive, very first treatment, and having her changing her lifestyle and taking good care of her lifestyle attitudes could probably be enough to have a long-lasting migraine management. I don't know if for the sake of time we've got time to go for a third case, or if you want to open the discussion now. I will ask the organizer.
No, you can go. You can go ahead, doctor. You can do it quickly. It's fine. Yeah.
Thank you.
Yeah.
Thank you, Dr. Maya. So this is the last case, case number 3, and then I swear I will let you go to sleep or to your family or to your needs. So it's a male patient, 38 years of age. He's an expat as well, with a BMI of 22. He is married. He has 1 child. He's a cabin crew, steward actually, with a strong familiarity for headaches from both mother's and father's side. He's sporty, he's fit, training quite regularly, with a good, healthy lifestyle, as much as possible, compatible with his working schedule. He's only a social smoker and social drinker, and he takes no more than 4 or 5 coffees per day, but not every day. He has quite a hectic lifestyle because, of course, of the continuous traveling because of his work. So he reported to have very frequent headache attacks, nearly 9-10 severe, strong headaches per month of throbbing, pulsating pain, temporal, orbital as localization, lateralized, sometimes on the right, sometimes on the left, with nausea, not really vomiting, but with also photophobia and photophobia of at least 1 full day of duration. He was using either a combination of ibuprofen 600 plus paracetamol 500, or a combination of sumatriptan 100 and either ibuprofen or paracetamol in case of failure of the sumatriptan, usually around 10-12 times per month. We'll see in the diary, but usually he was taking 5 to 6 times sumatriptan and the remaining times ibuprofen, or vice versa. But further digging, asking him more specifically, he was also reporting basically a background pain, also a nearly constant mild headache, like a heaviness, that was reported for nearly the majority of the month, 15 to 20 days per month, with this heaviness lingering in the background, mild pain sensation, never really bothered by nausea or phonophobia, unless it was one of the strong attacks. Then in that case, yes. This milder background headache was so mild, as per him at least, that he didn't even consider it as a proper headache and was not even taking any medication for that. He was just keep going through those headaches. So, thinking about the possible diagnosis, considering the criteria that we revised before for episodic migraine and for chronic migraine and medication overuse, what do you think could be the most fitting diagnosis for this young man with 8 to 10 strong migraine headache attacks per month and easily 15 to 20 milder headache days per month, with the treatment options of ibuprofen plus sumatriptan and ibuprofen or paracetamol, but no more than 10-12 times in a month. Opening the polling session.
We need 5 seconds to wait. Okay, now I stop the full and check the results.
And now let's see the results. Okay, so we have nearly 40% of the attendees going for tension type headache and a good 24% going for chronic migraine, and then only a minority going for medication overuse or migraine without aura. So let's give a look at the criteria. Reviewing again together the criteria. A lot of attendees, they voted for episodic or frequent, in this case, or tension type headache. Because, of course, the patient was reporting, and this is true, 15 to 20, so a high number of milder headaches, not bothered by nausea or vomiting, with only maybe occasionally photophobia, but nearly nothing, and mild to moderate intensity, which by itself, by themselves, of course, seems to be fitting in tension type headache class criteria, and I agree on this, but he was reporting this together with also enough criteria for migraine without aura, because he was having 8 to 10 attacks of migraine, of severe pain, unilateral pulsating of severe intensity with nausea and photophobia, phonophobia since a long time. So these two criteria combined actually are the criteria for chronic migraine. And if you look at the bottom left side of the slide for the chronic migraine criteria, at the subpoint A, headache, look, tension type like and or migraine like 15 days of headache per month for more than 3 months. So when a patient is reporting these long-lasting headaches with superimposed high-frequency migraine attacks for more than 3 months, these are criteria fulfilling the chronic migraine criteria. So this patient is not having both tension type headache and episodic migraine without aura. This patient is suffering by chronic migraine. And I agree that, of course, there is the risk again for medication overuse, even if it's not fulfilling the criteria because of the total number of painkillers he's taking, but is very close to. So medication overuse, maybe not every month, but maybe there were months that he could have been fitting those criteria. This is a sample of his headache diary, which is it's a bloodbath, basically. You can see the dramatic number of headaches, but look at the intensity, the severity. I circled the days where he was having the stronger attacks, so those fulfilling the criteria for migraine, which are 8 or 10, I think, and then the majority of the other days, there were only milder headaches, marked with the number 1 in the columns. And as you can see, the number of painkillers he was taking was not so high to fit into the medication overuse criteria. So for this case, the diagnosis is chronic migraine. MIDAS score was 42, which is grade 4, so the most disabling kind of migraine, so severity high. He already tried actually in the past amitriptyline and propranolol, but they were only partially effective, and they were having some mild but annoying side effects. So he was not satisfied with the results. He stopped them after several months actually of trying them because of only partial efficacy and side effects. So considering that he already tried amitriptyline and propranolol, which kind of treatment options we can consider for this patient? We can consider topiramate, erenumab, onabotulinum toxin, type A, greater occipital nerve block. We are talking about the case of chronic migraine in a young man, fit and sporty, steward for cabin crew, who already failed on amitriptyline and propranolol. Opening the polling session.
5 seconds to go. Okay, I'm stopping the polling session.
Okay, let's see the results. This is very, very Interesting. Okay, yes. So that's very. I'm very happy about the response rate and the answers. So topiramate and erenumab are definitely leading the charts, with erenumab in pole position, let's say so, and topiramate coming second, onabotulinum toxin coming third. This I wanted to comment on. So topiramate and onabotulinum toxin type A are the two medications that, before the advent of the anti-CGRP monoclonal antibodies, were the only two molecules, so topiramate and onabotulinum toxin, were the only two molecules with the indication for chronic migraine. And then we received the anti-CGRP monoclonal antibodies that have the indication for both episodic and chronic migraine. So all these three answers actually are potentially absolutely correct and right, because all these three molecules have the indication for chronic migraine treatment, while all other molecules you could try, but they don't have the indication as per guidelines. So the occipital nerve block, for example, there are several interesting case reviews and small sample trials and publications in the literature, but never reached so far the level of evidence strong enough to be considered recommended first-line treatment for chronic migraine. So looking at the case discussion for the treatments, considering that he's having a very hectic lifestyle, he's traveling and flying a lot, he already skipping a lot of meals or eating very irregularly based on time zone, flying schedule, and also considering that he needs a lot of concentration and focusing and being able to be interactive with people, topiramate, despite being a good option, probably would not be the ideal one for his case. Could have been considered as a second-line treatment. Onabotulinum toxin could have been a perfect call because it has the indication for chronic migraine, so it's officially approved by FDA and EMA, and also by DHA in the Gulf region, in the Middle East, in the Emirates. The only problem was that for this patient, he was already receiving Botox for aesthetic medicine, as the aesthetic medicine treatment. So he was already receiving onabotulinum toxin, and we couldn't give him additional units on top of the dose he already received for his aesthetic reason. Interestingly, he was not having big results, but we do know that to have a good answer, a good response on onabotulinum toxin, you need to follow the PREEMPT protocol. So if we use different dosages at different infiltration sites, you cannot have the same good results. So for this case, onabotulinum was not a good possibility. For this reason, we decided to go straight for erenumab 140 milligrams, full dose every 4 weeks to achieve, hopefully, a good answer. Looking at the outcome, at the first month follow-up visit, there was already a quite striking improvement. He was reporting 6 strong migraine attacks per month. Before, he was having 8 to 10 strong migraines per month, and only 2 mild migraines per week. Total number of headache days was coming down from 25, 28 to 10 to 14 headache days per month, globally speaking. And among those 10 to 14 headache days, only 6 were strong migraines. And what about the 3 months follow-up? Well, after 3 months of erenumab treatment, 140 milligrams every 4 weeks, he was reporting at a hereditary 15% reduction in the monthly migraine days. He was now having only 3-4 strong migraines per month, each month, and 1-2 milder headaches per week. So totally 8-9 headache days per month, which again, coming from 25 to 28 headache days, it's a dramatic response. At 6 months visit, the results were even more impressive. He was showing a 75% reduction on the monthly migraine days, reporting only 2-3 migraine attacks per month, now nicely responsive to triptans. So he was able to manage his migraines with a single dose of sumatriptan. Actually, sumatriptan 50 now became enough, and no longer using the 100 milligram dose, and no more most bothersome symptoms. What I wanted to discuss maybe later for the question and answer session is that what we do see for episodic migraine with the anti-CGRP monoclonal antibodies, we do see for chronic migraine. So the level of response we could expect for chronic basically is the same as per episodic migraine. They respond both extremely well to anti-CGRP monoclonal antibodies. And again, no side effects and no adverse events. Last poll, before going to the question and answer session, duration. Now here it's more challenging. How long we should keep this patient with chronic migraine as a diagnosis and high triptans intake and painkillers intake before on erenumab treatment? 6 months on 140, he responding so well, we can try to stop, or 12 months at least on 140 before stopping, or again, we can consider a hybrid pattern schedule with 6 months on full dose and then 6 months on the smaller dose of 70 and then try to stop, or any possible combination, of course. Let's see the voting. Let's see the results. So nearly 60% voted for 6 months on full dose and then 6 months on a smaller dose before stopping, and nearly 30% voted for 12 months of treatment on the full dose. So again, we know that there are no definitive data on this. I would be in favor for a case of chronic migraine, I would be in favor for a full year of treatment and then trying to taper down to 70 for a few months before stopping. So probably I would be in favor of the hybrid approach, but with a full year of treatment, because we know that patients with chronic migraine suffer from a dramatic load of disability and impairment of the quality of life, and we try to keep them migraine-free as long as possible. So going to the conclusions from these 3 cases, which are a good representation of what you do really see in the clinical practice. These are patients that I've seen, that you also have seen, or you will see in your clinics. We can generalize that erenumab is effective on both the 70 milligrams and 140 milligram dose. It's indicated, so it's allowed and has the indication, and it's also effective across the whole migraine spectrum, so can be safely and reliably used for episodic migraine, high-frequency migraine, chronic migraine, menstrual migraine. Across the whole spectrum, you will have the same amount of good results, with excellent safety and tolerability profile, especially compared to the traditional prophylactic oral old treatment and medications. And as we've seen, there are very, very strong data about the safety and tolerability, even for prolonged use. We've got data of more than 5 years of consecutive use of erenumab. The point that is still open, and the debate is hot in the headache specialist community, is the time to discontinuation, which is not very clear. It's based on a clinician decision. This is true. The main thing you have to consider is that the data we have so far from the real-world evidence is that many patients will have recurrence of the migraine if you stop them too soon. And so the ideal is to keep them for a follow-up in 3 months' time, because those who will start failing will start doing that in the first 3 months. So if they stay migraine-free or low frequency of migraine after 4, 5, 6 months after discontinuation, they will probably keep going like that for longer. If they have recurrence of migraine the first or the second, third month, those are the patients probably need to be restarted pretty soon. I hope that it was interesting.
Thank you.
I will open now the floor for the discussion.
Thank you, Dr. Alessandro. Actually, it was an amazing case discussion, and it was very enriching, and you consolidated all the theoretical data that Dr. Ali shared with us in his lecture. So we will open the floor to some question. So, Doctor, given that erenumab is an injectable drug, and we know from multiple sclerosis and other diseases that usually our patients do not adhere or do not like injectables as treatment for their diseases. So from your experience, how much patient they are adherent on injectable, and are you seeing injection site reaction on erenumab, and patient discontinuing erenumab because of injection site reactions?
So this is a very relevant question. I would say that in the beginning, so before starting, they can be a little bit reluctant or skeptical about this injection thing. But you have got two tools to overcome this initial resistance. One is if you can ask the pharmaceutical companies to provide you with a demo unit for these injectables. You can show the patient with a demo unit how the pen looks like, how easy and simple it is to inject, and how safe it is. You can offer to do this the first time, for example, in your clinic. So I do this for my patient the very first time. I ask them just to come in, to pop in between patients just for the injection, so they feel safe and they feel reassured. But once they start, and after the first month of treatment, they do see the results, they will no longer question about the injection thing. It will no longer be a problem. Because honestly, I would say that with all the monoclonal antibodies, we have so much better results compared to the oral agents that the patient do see the difference and they are not concerned about the injection. So adherence to the treatment is really, really high because they do see the difference for the very first month, actually. Injection site reactions, you can see them. Usually they're mild and minor. They can stay for half a day or a day with some redness and a little bit of itchiness. In the beginning, when we started using erenumab, of course, we're asking after each injection if the patient was having, take a picture with the mobile, send to me over WhatsApp, because we're concerned about this. We stopped. We no longer ask because the patient are really not bothered by that. Even if there is a mild injection site reaction, the patient will not give it relevance because they're very minor and self-limiting. In 4 years, I had only one case of allergic reaction on 2 different monoclonal antibodies. And we have, I don't know, maybe more than 500 patients treated so far. So honestly, they are super safe and very well tolerated molecules. The injection site reaction can be there, but will never be reported by your patients because it is a minor thing of no clinical relevance most of the times.
Another question, in case the patient discontinued erenumab after 12 months of clinical stability and the patient was well controlled, free of attack for 12 months, he discontinued erenumab, and after 3 months of discontinuation, he had reoccurrence of migraine attack. What would be the first line of treatment in this case? Do we restart your strategy of treatment?
So the answer is yes. We will restart erenumab. If it was, I mean, if it's not broken, don't fix it. So if it was working so well, it's worth starting it again. Keep in mind that we have to keep in mind that most of the patients, they do respond to anti-CGRP monoclonal antibodies, the majority. If they respond, they will keep responding. We know that the percentage of patients developing antibodies or neutralizing antibodies is super low, and they do not have any clinical consequences. So if the patient was responding before, he will respond even the next year or in 3 years' time if you have to start it again. And if the response rate was good, the results were satisfying for both you and the patient, there is no point in starting something different if he was having good results. I would say start again. The dose maybe can be discussed, but I would start the same monoclonal antibodies. We'll start, for example, in this case, on erenumab again after 3-4 months. Yes.
And Dr. Ali Hassan, in the discussion, he mentioned that erenumab should be stopped 3 to 6 months before conceiving because we don't have enough data about its safety in pregnancy. What do you usually do for those women who stop erenumab? Do we bridge them with any other prophylactic treatment or traditional treatment, or we just keep them off anti-migraine treatment and we monitor for the occurrence of an attack?
This is super relevant and very challenging question. So yes, we tend to stop it 3 months before the potential pregnancy or before looking actively for a pregnancy for safety reasons. And usually the recommendation, well, we know that the pickup rate of migraine after stopping monoclonal antibodies usually starts after 2 to 3 months. At least from the open data that we have from open world, real world experience. So recommendation could be, for example, to start magnesium supplementation, which can be a very mild but compatible with pregnancy prophylactic treatment that can be a sort of a bridging therapy, and then looking for the protective from migraine effect of the pregnancy with the stabilization of the estrogen levels. Most of the women do have an improvement in the second trimester of pregnancy of their migraines. So this could be an option, but also a wait and see protocol could be considered, addressing maybe lifestyle changes, the irregularity of the sleep pattern, for example, the amount of caffeine, coffee or tea. Tea contains caffeine as well as coffee, and try to manage these lifestyle also modifications to try to minimize the triggers for migraine. But other drugs, all of them basically do not have the indication for pregnancy. We can use beta blockers, for example, in very severe migraine and low dose amitriptyline. They are considered safe enough, but still they are not recommended in pregnancy. So we try to avoid any kind of pharmacological treatment. Devices for neuromodulation could also be considered, like the Cephally device. That's another option if the patient can afford it because it's not covered by insurances. But that's also another safe option for migraine prevention during pregnancy.
For example, other disease like multiple sclerosis, we usually don't advise the patient to get pregnant, a woman with childbearing age, until she has a stable disease. So if this applies to migraine, so usually a patient with childbearing potential who has frequent migraine attack and who was just started on erinumab or any other anti-CGRP, do you usually recommend her, for example, to avoid the pregnancy for 6 or 12 months until you stabilize the disease and you control the attacks, and then you can get pregnant, or no?
So no, I understand the topic, the point is really delicate. Of course, we are talking about a disabling condition, but not a sinister or life-threatening condition as multiple sclerosis. So I would probably consider 6 months of treatment a good enough period of time for the prevention, but I will not probably, unless the patient, of course, agrees and maybe they are not looking for a baby at the moment, they can stay even for a year, but I will not limit the decision for a pregnancy to keep them on a year or longer of anti-migraine treatment. 6 months, I think, could be enough. And then if they're doing well, they can start looking for a pregnancy because we are not facing a so dangerous condition as multiple sclerosis.
And a final question, it's not related directly to erinumab or anti-CGRP, but what is the mechanism behind?
I cannot hear you. The connection is a bit.
Overuse of pain medication.
Can you repeat?
Yeah, I'm asking you. So, what the mechanism behind the fact that overuse of pain medication can trigger?
Okay.
Did you hear me, doctor?
Yes, I think so. If I got it right, what is the pathophysiology or the mechanism behind the medication overuse headache, right?
Yeah.
So basically, I mean, to make a long story short, so basically what happens is that you have the stimulation, of course, of the pain receptors, but then you also try to reduce the amount of pain you are experiencing with anti-inflammatory or, let's say, painkillers molecules. But this trigger the sensitization of the cortex, and basically the cells start sprouting more receptors to increase the turnover of the receptor surface. So you need higher and higher doses of painkillers to achieve the same level of analgesia. And since the turnover is so high, you have relief from the pain for only a limited number of hours. and then the effect stops and drops, and then you've got the rebound headache. So basically you think that you are chasing the pain with the painkillers, but actually is the pain that is following your painkillers doses closer and closer. So the more you take, actually, the more you feed the painful mechanism, and you are no longer treating the pain, but you are really putting fuel on the fire, because you are accelerating this mechanism of resprouting of the receptors, and you basically go into tachyphylaxis and centralization. So it's pivotal, it's fundamental to try to stop the abused medication so that you start a more normal level of turnover of the receptors on the surface of the trigeminal cells. And you have to interrupt the abuse medication. So usually what we recommend is, for example, we give a prescription for 3 different categories. So one can be an anti-inflammatory, one can be a triptan, one can be a simple analgesic. But we recommend not to use the single category more than 8 times in a month, for example, or to alternate. One day use this, one day use that, and the third day use the third one. You're not allowed to use more than one per day. So this way you decrease the level of central sensitization and you decrease the overall exposure to painkillers, try to normalize the central response. Of course, you have to start a preventive treatment at the same time, because otherwise you'll never be enough.
Thank you, Dr. Alessandro. Those were the questions. And with Dr. Teruzzi enriching case discussion and excellent session, our 4th virtual clinic comes to its end. Thank you for our esteemed speaker. Thank you, Novartis, for sponsoring this activity. And the big thank you goes for you, our attendees, for staying with us until the end. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or would like to revisit the lectures, you can check our IVPN NeuroPsychiatry library, where we post all the recordings very soon. Follow us on our social media platforms and stay tuned for our next educational activity scheduled next week on June 30, and which will tackle a very hot topic nowadays, which is the use of generic drugs for the treatment of multiple sclerosis. So keep your eyes on our page, as where all the detail will be announced very soon. Until we meet again, stay safe and have a good night.
Marcelana, good night, everybody. Thank you.
Bye, doctor. Bye. Thank you, Dr. Ali. Bye.
Thank you. Bye.